Hello, everyone, and welcome to today's webinar, C. difficile testing, Conundrums, Guidelines, and Diagnostic Stewardship, presented by Dr. Karen C. Carroll and Dr. Masako Mizusawa. I'm Christy Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by BD. BD is a global medical technology company that is advancing the world of health by improving medical discovery, diagnostics, and the delivery of care. To learn more about our sponsor, please visit moleculardiagnostics.bd.com/bd-max-system/. Now, before we begin, I would like to remind everyone that this event today is interactive, and we encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them in the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have any trouble seeing or hearing the presentation, just click on the Support tab found at the top right of your presentation window, or let us know you're having a problem by using the Ask a Question box. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located on the top right of the presentation window and follow the process to obtain your credits. I now present today's speakers, Dr. Karen C. Carroll, Professor of Pathology and Director of the Division of Medical Microbiology at the Johns Hopkins University School of Medicine. Also presenting today is Dr. Masako Mizusawa, Assistant Professor, Section of Infectious Diseases, Department of Internal Medicine at University of Missouri, Kansas City. For complete biographies on our speakers, please visit the Biography tab at the top of your screen. Dr. Carroll, Dr. Mizusawa, you may both now begin your presentation.
Okay, thank you, Christy, for that introduction. Hello, everyone, and thank you for participating. Here is our disclosure slide, and I just want to mention that some of these companies do manufacture tests for the detection of C. difficile. So we hope today that at the conclusion of this presentation, you will have learned about the current challenges with C. difficile testing, the IDSA SHEA guidelines for diagnostic testing, and most importantly, interventions to improve C. difficile testing. The first pathological description of pseudomembranous colitis actually came out of Johns Hopkins in 1893. The patient was a 22-year-old woman described by William Osler as a miserable, emaciated creature in wretched physical condition. She underwent resection of a gastric tumor and did well until the 10th postoperative day, when it was noted that she was having bloody diarrhea. And unfortunately, she died 5 days later. On autopsy, she had what was described at the time as a diphtheritic membrane involving the terminal ileum and the colon. And if you look at the figure, this is the original photomicrograph of the histologic sections from this patient. It was almost 100 years later, however, before the link between pseudomembranous colitis, C. difficile, and its toxins was established. Between 1975 and 1980, there were several groups involved in the early work. Sin Feingold's group, John Bartlett's group. In 1977, Bartlett and colleagues established a hamster model, and this proved to be a very useful model for studying the pathogenesis of C. difficile. With this model, they demonstrated that clindamycin-associated colitis, which it was called at the time, was due to a toxin-producing strain of Clostridium. T-Wen Chang was the virologist in the group who characterized a cytopathic assay. Nancy Taylor was the biologist in the group, and she described toxin A, an enterotoxin, and toxin B, the cytotoxin. And in 1978, the authors published the landmark paper in the New England Journal of Medicine that firmly established the fact that patients with pseudomembranous colitis associated with antibiotics had C. difficile, toxigenic C. difficile, The next slide demonstrates the C. difficile cytotoxin assay that was developed by T1 Chen. On the left-hand side of the panel, you can see an uninoculated fibroblast cell line to which he applied filtrates of the stool of the patients with pseudomembranous colitis. And in the middle panel, you can see the characteristic cytopathic effect with rounding and density of the nuclei and spiculations. And this is very characteristic now of the toxigenic effect of C. difficile. And he was able to actually neutralize the cytopathic effect by using C. sordelli antitoxin. The researchers used this assay to study the epidemiology of C. difficile disease between 1978 and 1980, and in the box on the right-hand side, you can see some of that data. So in patients that had confirmed pseudomembranous colitis due to antibiotic-associated diarrhea, almost all of them had C. difficile toxins in their stool. However, only 27% of patients with antibiotic-associated diarrhea and no confirmed pseudomembranous colitis had C. difficile toxin in their stool. Also, an important observation is that antibiotic recipients with no diarrhea could also excrete C. difficile toxin in their stool, and in this particular study, it was about 2%. In addition, the authors also confirmed the earlier results of Hall and O'Toole. These were, as you may recall, the individuals who named the organism as Bacillus difficile. In healthy infants, they demonstrated that 27% of these individuals had C. difficile toxins in their stool, and hence the recommendation not to test infants less than 2 years of age routinely for C. difficile without compelling clinical and epidemiologic information. So the cell culture neutralization assay became the standard reference method for C. difficile diagnosis. It was 100% sensitive in the hamster model. In humans, however, false negatives were seen due to procedural problems such as overdilution. False positives were also seen to occur as a result of procedural errors in the filtration and dilution steps. Also, false positives could be attributed to asymptomatic patients who harbor toxin-producing strains. It's important to point out that CCNA was never standardized for use in clinical labs. It's not easy to perform, it's not rapid and not reproducible, and therefore clinical labs look for alternative methods to perform testing for this disease. This led to the manufacture of enzyme immunoassays, which use monoclonal or polyclonal antibodies to detect toxin. Interestingly, enzyme immunoassay development began soon after the discovery of C. difficile and its toxins, but it was observed to be tenfold less sensitive than cytotoxin testing, and hence was not pursued at the time as a viable option for diagnosis. The first antibody-based C. difficile assay was marketed in 1986. This was the Culturette brand rapid latex test. It was designed to detect toxin A in 30 minutes, which would have been a fantastic advance. However, what it actually detected was glutamate dehydrogenase, the common antigen found in toxin-positive and toxin-negative C. difficile. Other commercial toxin A and toxin B assays followed. However, as this clinical study, again performed at Hopkins, demonstrated, clinically enzyme immunoassays were shown to lack sensitivity. This study was performed by Dr. Bartlett and Dr. Yuka Manabe on 268 non-oncology patients, and the authors observed that when using an EIA only, the accuracy for detection of C. difficile was only 72%. But they could improve detection by sending multiple samples on the same patients to compensate for the suboptimal EIA performance. And so the institutional practice at Hopkins, and actually other laboratories, I'm told, became stools for C. diff ×3. I arrived to Hopkins in 2002, and shortly thereafter, I began to get a series of complaints that prompted us to reevaluate the C. difficile EIA test in use in the lab at that time, and much to our dismay, we found that the sensitivity of that assay had fallen to 38%. And therefore, we switched to the cell culture cytotoxicity neutralization assay. Literature from others followed, which duplicated our results. And in 2008 and 2009, two wonderful reviews were published on the 6 Tox-A/B tests in use at the time, which demonstrated that none of them met the acceptability criteria, which the authors defined as a sensitivity of 90% and a false positive rate of less than or equal to 3%. And so enzyme immunoassays were declared suboptimal. So what was happening during this time? Well, these two studies published in the New England Journal of in 2005 demonstrated that in North America, we were seeing the emergence of epidemic toxin variant strains of C. difficile. In the study by Cliff McDonald, 50% of 187 isolates were found to be NAP1 strains by pulsed field gel electrophoresis and ribotype 027. Compared to the historical NAP1 strains, these new strains were fluoroquinolone resistant. They also seemed to be hyperproducers of toxin. In addition to that, also hypersporulators, and so they were more easily disseminated throughout the hospital environment and also caused more severe disease. The increased severity of disease caused by these strains was very much apparent in the Quebec study among 12 different hospitals, where 6.5% of patients required intensive care and 1.9% required colectomy. More importantly, the 30-day attributable mortality in that study was 6.9%, whereas the baseline was 1.5%. So clearly, this emergence of this strain refocused attention on diagnostic testing. So many laboratories were looking for alternatives to EIAs. Glutamate dehydrogenase assays began to appear. Again, this detects highly conserved common antigen present in both toxin-positive and toxin-negative strains. There were two formats that became available. The first format was a solid-phase microtiter plate assay, which we implemented in our laboratory, and then later on, lateral flow devices that combine GDH detection with toxin A and B detection became available, and this actually simplified testing. So GDH was incorporated into multi-step algorithms, and meta-analyses showed a greater than 90% sensitivity for the GDH components of these tests. So we implemented a two-step algorithm at Johns Hopkins that you see here. If the sample was GDH positive, then we confirmed that it was a toxin producer using the C. difficile cytotoxicity neutralization assay. But the problem with that was that the time to a positive result could require up to 72 hours, and so this really wasn't a good solution. Of course, now with the lateral flow assays, the time to positivity is much quicker. However, we realized that we needed a sensitive test and a more rapid test. So we started thinking about molecular testing. And early reports using PCR appeared in the literature in 1991. These were end detection assays. Because we were dealing with stool, the extractions were quite cumbersome, and we saw cross-reactivity with other Clostridium species in those early PCR assays. However, a decade later, we had DNA extraction methods from fecal samples that improved. We had real-time platforms which became available, and the analytical sensitivity of PCR was compared to CCNA was much higher, 10 to 100 times more sensitive, for example, in many studies. The analytical specificity also improved. The first FDA-cleared platform became available in 2009, and this was the BD genome assay, and we did implement this assay in our clinical laboratory. Now, however, we have this embarrassment of riches, as demonstrated on this slide. The last time I looked at this, there were more than 13 FDA-cleared nucleic acid tests available for the detection of C. difficile toxins in stool. Shortly after we implemented the PCR test in our laboratory, we began to get lots of questions from clinicians. These were very thoughtful questions, and I think they're still relevant today. Some of the questions were practical. These assays detect genes encoding toxins and not the toxin itself, so can they reliably predict disease? And what will be the impact on CDI rates when switching from an insensitive test like EIA to PCR? And I did forewarn our infection control team that they were going to see an increase in their PCR rates. I'm not going to talk about theoretical concerns, although I think these do need to be considered. And then in terms of other questions, will the use of NATs lead to reductions in C. difficile transmission? I will talk a little bit about that. What will be the impact on patient care? And are NATs cost effective? And there's been at least one paper in the literature early on that demonstrated that NATs can be very cost effective in terms of the diagnosis of C. difficile. So this brings us to infection control and the National Healthcare Safety Network. So a positive C. difficile test taken greater than 3 days after admission constitutes hospital onset CDI lab ID event. And when this requirement first came out, any positive C. difficile test was considered a lab ID event. However, in 2018, the National Healthcare Safety Network updated their requirements and to accommodate two-step testing. And if a laboratory is using a two-step test, you only need to report this as a lab ID event if both tests are positive. So this does help those laboratories that are using a two-step algorithm. However, it does not help those laboratories who have chosen to use NAT alone as a single test. This was designed to be a patient safety metric. However, it does not incorporate chart review or take into consideration patient symptoms, and of course, it's greatly influenced by test characteristics and ordering behaviors in an institution. So I do have permission to show you this slide from our infection control team, and what it illustrates is if you are going from a relatively insensitive test such as CCNA to a nucleic acid test, this will give the appearance of an increase in your transmission rate. However, what it really is pointing out is better detection. And so we did observe that in our hospital environment. But look at what happened in the year after we implemented the PCR. Because we were doing PCR more frequently and because it was a more sensitive test, patients were getting placed on contact precautions much more quickly, and with improvements in hand hygiene and other infection control bundles, we actually saw a true drop in the number of C. difficile transmissions. When our infection control team did some chart review, the other observations that they made is that when you applied a clinical definition, the actual transmission rate was even lower. And this suggests that perhaps there was some overutilization of the C. difficile NAT test. And if you look at 2016, when we implemented the EPIC project that Dr. Mizusawa will be addressing in the second half of this presentation, we were actually able to reduce transmission even more. So the next several slides talks about some of the literature that informed the IDSA SHEA guidelines. And this study by Duberky et al. Highlighted the importance of clinical symptoms in assay interpretation. This was a study of 9 assays, including 3 NATs, and they used 2 reference standards with and without symptoms. What was nice about this study is that it was prospective, and they used patient interviews and physical exams in terms of interpreting some of the test results. Not surprisingly, NATs had the highest sensitivity but the lowest specificity of all the test methods, and the specificity and positive predictive value for all assays increased when clinical symptoms were ignored. The specificity, there were 2 other very important observations. 36% of Patients did not have clinically significant diarrhea, again suggesting overutilization of testing, and 20% of patients were on a laxative at the time of testing. When we looked at our rates at Johns Hopkins, shockingly, it was 44% on some of our medical units. There were two other very important studies that did help inform the IDSA guidelines. The first study came out of the UK by Planch et al. This was a multi-center observational study of C. difficile infection, and the authors intended to validate tests based on clinical outcomes. They compared 4 commercial assays, EIAs, GDH, and PCR, to 2 reference methods, the cytotoxin test and toxigenic culture. And what they observed is that patients who were CCNA positive had higher mortality and more severe disease than culture positive or PCR positive toxin negative patients. And that the best predictor of C. difficile disease was actually the cytotoxin test. But because of the problems that I highlighted with CCNA, their final recommendation was to use a 2- and 3-step GDH-based combination test, and they saw this as the best option for patient care. And so the standard of care in the UK is to use a 2-step algorithm based upon GDH and a, quote, sensitive toxin EIA test. The second study was performed by Polish et al. In the United States. This was a prospective observational study of over 1,400 patients. They compared toxin EIA, which was the standard of care in the institution at that time, to PCR. And they asked the question, do toxin-negative, PCR-positive patients require treatment? And if you look at the second bullet point, the toxin-negative, PCR-positive patients had milder and shorter duration of symptoms. 58.7% of those patients were not retested, indicating that the physician likely thought that they didn't have disease in the first place, and then only 13% actually received a full course of treatment in spite of the negative toxin test. 18 of 19 C. diff-related complications and deaths occurred in toxin-positive patients only, although there was 1 death in a patient who was toxin-negative PCR positive who did not get treated because of that test. So on the flip side, however, there are several studies, albeit they are smaller studies, that actually show a lack of correlation of toxin positivity with disease severity. And what most of these studies have in common is that the patients are immunocompromised. In the Guerrero study, which was done in a VA, a third of the patients with CDI would have been missed with an enzyme immunoassay only, and 21% of those patients had severe C. difficile infection. In the Humphrey study, the presence of toxin did not correlate with disease severity. In the Colitis study also, there was no difference in severity or mortality between groups, although the toxin-positive patients had higher recurrence rates. And in the ERB study, EIA positive and EIA negative, but toxigenic culture positive patients also had similar outcomes. That study was actually kind of interesting. They did not look at nucleic acid amplification tests, but what they did observe is that in this patient population, if they had relied upon EIA only, they would have missed a significant proportion of patients who had moderate to severe disease. So now we come to the guidelines. So the IDSA and SHEA professional societies put together a 14-member panel that examined new information published between 2009 and 2016. They used the grading of recommendations assessment, development, and evaluation system to assess the strength of evidence for each recommendation. The new guidelines also included pediatric-specific recommendations that were absent in the 2010 version, and the guidelines address the epidemiology, infection control, diagnosis, and treatment of C. difficile disease. So this slide speaks to the guidelines on diagnosis. The first recommendation is if no institutional guidelines for stool submission are in place, then laboratories are directed to use a stool toxin test as part of a multi-step algorithm. So you can see this could be a glutamate dehydrogenase plus toxin EIA, and again, the guidelines specify a, quote, sensitive toxin EIA. You can do GDH plus toxin EIA and perform NAT if the EIA is negative and the GDH is positive, or you can begin with a NAT and then confirm the NAT positives with a toxin test. And the second recommendation states, however, is if there are pre-agreed institutional criteria for stool submission, then a NAT test alone may be used. So what did the committee have in mind here? Well, what we had in mind in terms of these institutional criteria were whether or not there were stool rejection criteria by the laboratory for stools that were not liquid or soft, and also whether or not the institution had a way of assessing whether patients were receiving laxatives and other particular criteria that are described in the guidelines. In addition to these two recommendations, the guidelines also state not to routinely perform CDI testing in children with diarrhea 12 months of age or younger, and also to consider excluding other causes of diarrhea first in children 1 to 2 years of age before testing for C. difficile. So with that, I am going to end my session, and Dr. Masako Mizusawa will talk about what laboratories can do to improve test utilization so that perhaps a single-use NAT might be appropriate for a particular setting. So with that, Dr. Mizusawa, I will turn this over to you. Thank you.
Thank you, Dr. Carroll. Hello, everyone. From here, I would like to discuss what laboratories can do to improve C. difficile test utilization. Unfortunately, we currently do not have a diagnostic test that can reliably differentiate C. difficile infection from colonization. If the tests are not ordered appropriately, we may detect colonized C. diff, which can lead to unnecessary CDI treatment, unnecessary hospital stay, and associated healthcare costs. It can also lead to increase in the number of hospital-onset C. diff cases reported to CMS through National Healthcare Safety Network. Common pitfalls in C. difficile diagnosis include testing C. diff for patients on laxative, testing for stool, repeating tests in a short interval, and testing for cure. And all of them can lead to detection of colonized C. diff. So it is important for clinicians to know when to test and when not to test so that they can select appropriate patients for C. difficile testing. One of the solutions to overcome those pitfalls is to form a diagnostic management team and break down the communication barriers between clinicians and laboratories so that we can work together to improve the test utilization and the quality of diagnosis as a team. There are many interventions to improve test utilization. Computerized Clinical Decision Support, CCDS, is one of them. CCDS is a health information technology to assist clinicians' decision-making and implement evidence-based practice by providing diagnostic and treatment recommendations. It can be in a variety of forms, such as pop-up alerts, information displays or links, or targeted highlighting of relevant data. In general, alerts are known to be only modestly effective at best due to alert fatigue caused by excessive numbers of warnings and overwritten alerts. In addition, various unintended consequences have been observed after introduction of CCDS alert systems. Now, I would like to share our experience with introduction of CCDS for C. difficile testing at Johns Hopkins. CCDS in electronic health records for C. difficile testing was introduced at 3 hospitals in the Johns Hopkins Health System, initially at Johns Hopkins Hospital in October 2016, followed by 2 affiliated community hospitals, Howell County General Hospital in December 2016, and Suburban Hospital in January 2017. Our electronic health record was EPIC. C. difficile testing used in Johns Hopkins Health System is a single test algorithm using detection of TCDB gene by nucleic acid amplification. Criteria for inappropriate C. difficile testing in CCDS are laxative administration within 48 hours, negative C. difficile test result within 7 days, and positive C. difficile test results within 14 days of test ordering. If a test order meets any of those criteria, best practice alerts are activated and providers are required to obtain test approval to process the order. Our best practice alerts have 2 components. The first BPA works as a soft stop, and the second BPA works as a hard stop. And I will explain how they work in the next slide. In order to ensure that the intervention did not cause any unexpected harm on patient care, retrospective chart review was conducted for all 3 hospitals for 3 months after introduction of CCDS. This is the first BPA screen. Physicians are offered multiple opportunities to change their mind and not to pursue testing. In this yellow box, physicians will see the instruction to send only a liquid stool and test only where the patient have 3 or more unformed stool within 24 hours. Criteria for inappropriate C. difficile testing are listed here as well. If ordering providers would like to learn more about appropriate C. difficile testing, they can consult this 1-minute guide, and if they click on this link, it will take them to a 3-page long PDF document about appropriate C. difficile testing with scientific evidence. Lastly, here is the best practice alert with a stop sign and the specific criteria that activated the alert. In this case, it was positive test result within 14 days. Here, providers are instructed to call the microlab to obtain approval if they still think C. difficile testing is necessary for their patient. On the right lower corner, there is a sign button as if providers would be able to override the BPA. However, if they click on the sign button and try to override the first BPA, the second BPA screen pops up and informs the providers in more obvious way that they cannot proceed further and they need to call the microlab to obtain test approval. By calling the microlab, ordering providers can obtain a secret test code for another test order called Approved Microbiology Test C. This is a screen for this new test order. They will be asked to enter a name of a technologist who approved the test here. Their approval request is never rejected as long as they make an effort to call the microlab to obtain approval. The microlab keeps a call log to document when and who called for approval for which patient. This is a statistical process control chart that was generated to compare the average weekly number of the C. difficile tests before and after the introduction of CCDS. The red vertical line represents initiation of the intervention. A solid line with a dot represents the number of C. difficile test orders per 1,000 inpatient days, and a dotted line with a triangle represents the number of positive C. diff tests per 1,000 inpatient days. We found that the average weekly number of C. difficile test orders per 1,000 inpatient days significantly decreased after the introduction of CCDS at Johns Hopkins Hospital, Howard County General Hospital, and Suburban Hospital. So introduction of CCDS led to reduction of inappropriate C. diff testing orders in both academic and community hospital settings. We also look at the number of BPA activation that resulted in completion of approved tests. Completion of approved tests means that physician called the microlab to obtain approval, ordered another C. diff test with a secret test code, sent stool specimen to the microlab, and tests were completed. The test completion rate was 34.5% at Johns Hopkins Hospital, 11.1% at Howard County General Hospital, and 12.4% at Suburban Hospital, which suggests that many providers eventually decided not to pursue testing after they activated BPA. We also evaluated physicians' reaction to the first BPA and the second BPA separately. The first BPA compliance suggests that providers saw the first BPA screen and decided not to test without clicking on the sign button to attempt overriding alert. The second BPA compliance suggests that providers attempted overriding the first BPA by clicking on the sign button and activated the second BPA, but stopped at that point and did not obtain approval to pursue testing. Approval obtained suggests that they did not follow BPA at all and pursued testing. At first interaction, 15.4% of providers were compliant with the first BPA. 57.7% were not compliant with the first BPA, but compliant with the second BPA. And 26.9% did not follow BPA and obtained test approval. In the retrospective chart review, there was no significant difference in age, gender, and CDI risk factors between patients for whom test approval was pursued and those for whom test approval was not pursued. The most common criteria that activated BPA was laxative use within 48 hours. The most common reason for pursuing test approval was diarrhea followed by leukocytosis. Of note, the proportion of test orders that met clinical definition of C. difficile infection was 56% at Johns Hopkins Hospital, 50% at Howard County General Hospital, and 54% at Suburban Hospital. This result suggests that many providers ordered C. difficile testing when their patients had 1 or 2 bowel movements within 24 hours. We also evaluated safety outcomes of the patients for whom test approval was not pursued in order to make sure that those patients did not have adverse events associated with CCDS. There was no delay in CDI diagnosis. There was no empiric CDI treatment without testing. And there was no colitis of unknown origin that could have been undiagnosed CDI. Of note, 21% of the approved tests were eventually not performed due to lack of stool specimen submission. So I just wanted to share another example of CCDS for C. difficile testing in a different EHR system because your institution may not have EPIC. This EHR is Cerner, and when I started working at my current institution, which is University of Missouri, Kansas City, after finishing my medical microbiology fellowship at Johns Hopkins, the repeat testing restriction by itself already existed as a rule built-in laboratory order system. So I suggested adding CCDS that incorporates medication administration record to check for laxative use and stool counts on the flow sheet for frequency of diarrhea, but it was not feasible by the Cerner team at that time. Instead, Cerner was able to create this CCDS in a relatively short period of time. When providers order C. difficile testing, 2 drop-down boxes are shown for them to answer yes or no to the questions regarding laxative use and frequency of loose stools. As long as they select either yes or no, they can click on the sign button. The correct answer is yes to 3 or more loose stools within 24 hours and no to laxative use within 48 hours, and then they can process the order. However, if they select the wrong answer, the alert pops up to inform providers that the test order is not appropriate. There is a sign button here as if providers could still override the order, but if they click on OK on the pop-up alert, the screen disappears with the order that they were working on, and if they still want to pursue testing, they have to start over from the beginning. This CCDS is not exactly a hard stop because providers can process C. difficile test orders as long as they know what to select for those questions in the drop-down boxes, but it can at least remind the providers of checking laxative use and frequency of diarrhea for appropriate testing. Lastly, I would like to mention briefly about one more potential intervention to improve test utilization. It is C. diff PCR cycle threshold value. There are multiple studies that evaluated correlation between the lower than cutoff CT value and positive toxin EIA and/or CCNA testing results, as well as correlation between CT value and clinical outcomes such as disease severity, mortality, recurrence, and diarrhea. Some studies found significant correlation, whereas others found no significant correlation. Given conflicting data on clinical utility, validation studies at own institution would be necessary for introduction of PCR cycle threshold as a predictor of free toxin. C. difficile test diagnostic stewardship interventions include repeat testing restriction in specific intervals by creating rules in the laboratory order system, EHR-based computerized clinical decision support to prevent inappropriate C. diff testing orders based on repeat testing restriction rules, laxative use, or frequency of diarrhea. Test order cancellation after 24 to 48 hours if no stool specimen arrives in the laboratory, so that the specimen won't be sent later despite the patient's clinical improvement just because the orders remain active for nurses. Reporting predicted presence of free toxin based on CT value could be considered if validation studies at your own institution ensures clinical utility. In summary, C. difficile continues to cause substantial disease burden. The diagnostic test pendulum has swung from toxin tests to molecular assays with a call to reinstitute toxin testing. Clinicians should partner with laboratories to ensure appropriate test utilization regardless of the test method. Thank you for your attention, and now we would like to open up for questions.
Thank you, Dr. Carroll and Dr. Mizusawa, for your informative presentation. Yes, it is now time to start the live Q&A portion of our webinar. Now, while Dr. Carroll and Dr. Mizusawa are going over the questions, I'd like to remind our audience how to submit those questions. Just click on the Ask a Question box located on the far left of your screen. Now, we'll answer as many questions as we have time for, and those questions we are unable to answer live, and those submitted during the on-demand period will be answered via the email address you provided at the time of registration. Okay, let's get started. Our first question, we've got some great questions coming in. Let's start with this one. Okay, it's a little long, so bear with me. Could you please speak to the current discussion about GDH toxin discordant reflex to PCR versus PCR positive reflex to toxin and only toxin result reported? This is for NHSN CMS reporting. Now, we use GDH toxin reflex discordance to PCR, and we report final results of PCR test. We also have laboratory protocols in place to evaluate stool consistency, laxatives, repeat testing, and this is used for rejection. Physician must call lab to get approval to override cancellations. Dr. Carroll or Dr. Mizusawa, would you like to comment on this?
Sure, this is Dr. Carroll. So first I want to congratulate you for having protocols in place to reduce inappropriate test utilization. That's excellent. I think the algorithms that you have mentioned are all approved by the IDSA guidelines. I think the GDH toxin discordant reflex to PCR is probably the more popular one and the one that frankly makes the most sense to me. You can also, it is also a guide in the guidelines that you can start with nucleic acid testing and reflex to toxin. In our environment, however, I would have concerns about only reporting those that are toxin positive and PCR negative. I feel that especially if you have already taken steps to improve the pretest probability in a complex hospital environment where you're not just dealing with a general patient population, but if you have a large number of immunocompromised patients, I'm of the belief that EIA alone is not sufficient in that patient population. So I don't really favor that particular algorithm. That's my personal opinion. The guidelines, however, do allow you to do that.
Thank you, Dr. Carroll. Now our next question. Please explain the rationale behind the two-step algorithm. This will still not differentiate between CD infection versus colonization.
I agree.
I agree too.
So I have never really understood that. Even though we had implemented it in the interim between the availability of nucleic acid tests and when we abandoned our EIA testing, so I agree.
Thank you. Okay, let's move on to our next question. Let's see, we have so many great questions coming in. How about, okay, this one, Dr. Mizusawa, this is for you. What criteria did laboratory staff use when called for test order approval?
So there was no criteria for approval. The technologists are not going to obtain any clinical information. They just need to call the microlab and ask for the approval, and then everybody gets approved.
Thank you. Now our next question. Do you have any recommendations for when both PCR C. diff and enteric pathogen panels are ordered? Pathogen panel includes C. diff. Should the C. diff run first and further testing discontinued if C. diff is positive?
So I'm presuming you're talking about the enteric pathogen panel tests or GI panel tests that include C. difficile. Since the laboratory really cannot make an assessment about clinical relevance in those scenarios, I really feel like there should be some discussion with the clinicians about the appropriate use of the panel tests that do include C. difficile. I know that some institutions who have embraced the GI panels, the broad-based GI panels, have elected not to report the C. diff and really offer C. diff testing independent of the GI panel. So I think it's difficult for me to answer the question directly without knowing, the clinical circumstances surrounding how the testing is performed in that particular laboratory. So I think this is a decision that the lab cannot make by itself. I think there needs to be some discussion with GI, infectious disease, stewardship, infection control, anyone who's willing to sort of help you with those algorithms.
Thank you, Dr. Carroll. Now, when seeking approval from the microlab, when a provider receives a hard stop when trying to order C. diff testings, what questions are the microlab staff asking of the provider?
So again, they do not obtain any clinical information. They just obtain the name of the provider who called the microlab and the patient that they would like to test the C. diff for. That's it. They don't need to explain why they still would like to pursue testing.
Thank you, Dr. Mizusawa. Our next question. Can you speak more to why you decided to continue with NAT testing? Do you use just NAT, or do you use the toxin test as well?
Since we had sort of studied this in our environment, and we were aware that we were having overutilization issues, particularly with respect to patients on laxatives, we elected to try to improve the pretest probability of nucleic acid testing as opposed to confirming a sensitive test with an insensitive test and not address overutilization issues at all. And let me just back up a little bit and let you know how we arrived at this decision. This was not a decision that I made independently. When the paper by Chris Polish was published, I assembled a multidisciplinary group that included a GI physician, several infectious disease specialists who had an interest in enteric pathogens, pediatric infectious disease, infection control team, some of our community hospitals, and antimicrobial stewardship. So it was a big group of people. We had probably 30-plus individuals who attended the meeting. We reviewed the paper. We felt that there were some limitations in the paper. We also felt that the patient population was perhaps a little different than our patient population. And, I forgot oncology. There was an oncologist there as well. And it was the consensus that, I sort of gave you the history of testing at the Johns Hopkins Hospital, was the consensus that given our patient population, we would like to try to improve the positive predictive value of what we consider the most sensitive test for detection of C. difficile disease, and therefore we would work on trying to come up with an EPIC solution, an educational campaign, and then some hard stops surrounding some of the areas where we appreciated that there was overutilization. For example, testing patients who were on laxatives. So that was our journey. You know, we started with the working group. You saw the little slide of the huddle. Was a big huddle, and then Dr. Claire Rock, who is one of our infection control specialists, really grabbed us by the horns and moved the EPIC hard stop solution forward, along with Dr. Mizusawa and one of our EPIC researchers. Sorry for the long-winded answer, but it really has been a journey.
Thanks, Dr. Carroll. Now, have you studied the costs associated with NATs versus two-step algorithm, taking into consideration the number of actual negative tests where financial resources would be utilized unnecessarily?
You know, we try to get a health economist involved in our project, but I don't think we were very successful. It would have been wonderful to have had that individual join our team, but unfortunately, I can't really speak to that. I apologize.
How much additional work or time do you spend answering calls for extra C. diff testing?
Do you mean as part, well, can we clarify a little bit? So in terms of part of the algorithm, actually, I questioned my text this morning again. Originally, we were doing this, we were getting 1 to 2 requests to override the hard stops and give them the, quote, secret code per day. Now it's really dropped off considerably. It's more like 1 to 2 requests per week. So I think people have just gotten used to it. We hope that's the reason.
How did you educate the clinicians before implementation? Were there any complaints?
Dr. Rock did a lot of education, but one of the wonderful things is we have a high-value care committee here at Johns Hopkins that looks not just at C. diff testing, but looks at overutilization of a broad range of other tests, including X-rays and other radiologic studies. And so we had house staff buy-in. We had those members of our medical house staff who are very much interested in high-value care and test overutilization help with the educational campaign. We started with putting the pop-ups in EPIC first before we implemented the hard stops in order to educate people. We did some measurements around that, and of course, due to alert fatigue, most people disregarded the pop-ups. Not most, but a significant number disregarded them. Although we did see a drop, it was not statistically significant. Dr. Mizusawa probably has more information about this. But we had good buy-in from the house staff. And since it's mostly the house staff who place these orders, I think that's the reason it was successful.
What determined the 7-day wait for retesting of negative C. diff?
This was based upon several papers in the literature.
Okay, now is it acceptable by IDSA guidelines to perform the GDH toxin assay and to report as negative when GDH positive toxin negative without reflexing to PCR?
Yes, yes. So the IDSA guidelines do allow you to do a 2-step or 3-step algorithm. So yes.
Okay, and looks like we have time for just a few more. This one's a little long, bear with me. In 2019, NHSN added this. When using a multi-step testing algorithm for CDI on the same unformed stool specimen, the finding of the last test performed on the specimen that is documented in the patient, lost my place here. Documented in the patient medical record will determine if the CDI positive laboratory assay definition is met.
Right.
This has led the C-suite community to push for NAT first and reflexive positives to free toxin testing to reduce the number of NHSN reportable lab ID events.
Yes.
Are you aware of any NHSN or CMS discussions of the promotion of this approach and its effect on CDI rates in an institution?
Yeah, unfortunately, I don't know of the discussions that are occurring, but the person who framed this question is absolutely correct. And I've had enormous pressure to do this as well, although there isn't good consensus among our clinical staff. I do know that that our infection control folks have tried to make the case, at least with NHSN, that Hopkins should not be penalized for using a sensitive single test method when others are sort of gaming the system by confirming their NAT with an insensitive EIA test. So it has been very much brought to the attention of, well, I should say CDC, through our infection control team. And we argue, that we have improved, test utilization to the point where we do feel that while we have not completely eliminated poor testing practices, we certainly have significantly reduced them. So that is a very good question and sums up exactly the conundrum that faces labs that really have studied this in their own environment and prefer to use NAT tests combined with some sort of computer decision report to improve testing. And by the way, I think even though some of these other test methods are insensitive, it still makes sense to try to reduce inappropriate testing across the board, regardless of the test method that you're using.
Thank you, Dr. Carroll. Now, Dr. Carroll and Dr. Mizusawa, do either of you have any final comments for our audience?
I just want to thank everyone for attending, and we hope that this was useful.
Yeah, I would also like to thank you for your attention. I hope the information that we provided will be helpful for your practice.
Thank you again, both of you, for your time today and your important research. And we'd also like to thank LabRoots and our sponsor, BD, for underwriting today's educational webcast. Now, before we go, I would like to thank the audience for joining us today and their interesting questions. Again, just a reminder for those questions we did not have time to answer today and those submitted during the on-demand period, they will be addressed by the speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. A quick survey will now pop up on your screen, and we appreciate your participation as it helps improve our webinar program. Thanks again for joining us, and we hope to see you again soon. Goodbye.